Wishing you all a very good day. This is Dr. Nandhini from the Department of Pediatric and Preventive Dentistry, working as Assistant Professor from Vinayaga Mission, Sankaracharya Dental College. Today I am going to talk about the topic early childhood caries. To start with the introduction, a good laugh and a long sleep are the best cures in a doctor's book. To start with this version, these are the contents that we are going to discuss about today. Starting from the synonyms and definition, classification, etiologic factors, risk factors, the prevalence of early childhood caries, clinical appearance, diagnosis, management, prevention and conclusion. This is according to the definition of American Association of Pediatric Dentistry given in the year 2003, where they define ECC as presence of one or more decayed, missing or filled tooth surfaces in any primary tooth of 72 months of age or younger. It is also called by some authors as rampant caries of the young. Childhood dental caries are maternally derived Streptococcus mutans disease. In children younger than 3 years of age, any sign of smooth surface caries is considered as SECC, that is severely early childhood caries. From ages 3 through 5, one or more cavitated, that is missing due to caries, or filled smooth surfaces in primary maxillary anterior teeth, or decayed, missing or filled score of greater than or equal to 4 for the age of 3, greater than or equal to 5 for the age of 4, greater than or equal to 6 for the age of 5 surface constitutes severe early childhood caries. So next is about nursing bottle caries. The definition of nursing bottle caries is not dependent on the number of teeth that is affected. It is dependent on the child's dental age, position of the affected teeth and the causative factor. It is a rampant form of early childhood caries. There are many terms that we use for ECC, that is nursing bottle caries, nursing caries, baby bottle caries, nursing bottle syndrome, milk bottle syndrome, bottle mouth caries, baby bottle tooth decay, infant tooth decay or the soother bottle caries. So there are different types when we talk about early childhood caries. Type 1, it ranges from mild to moderate, where the caries lesion is found to involve the molars and incisors seen in the age group of 2 to 5 years of age. It is mainly a combination of cariogenic semi-solid, solid food with improper oral hygiene practice that is followed by the infants. Number of affected teeth usually increases as the cariogenic challenge persists. The next is about type 2. It ranges from moderate to severe. It involves labiolingual caries lesion affecting the maxillary incisors with or without molar caries depending on the age of the patient. It is seen soon after the first tooth erupts in the oral cavity. Here the mandibular incisors are not affected. Cause is mainly inappropriate due to improper feeding practices and a combination of improper oral hygiene. Unless controlled, it might lead to the next stage, that is more than the severe and traumatic stage. This is type 3 ECC severe, where the caries lesion involves all teeth including the mandibular incisors. Usually seen in age group of 3 to 5 years. It is a combination of improper oral hygiene and improper dietary pattern followed by the kids. It is rampant in nature and involves immune tooth surfaces. This is about the types that we talked previously. On the stages, it is classified into different types. The first is the initial stage or stage 1. It is characterized by appearance of chalky, opaque demineralization of the smooth surfaces. Here the maxillary primary incisors with the child age group of 10 to 20 months or sometimes even younger is affected. At this age, the lesion is reversible. The lesions can be diagnosed only after the affected teeth have been thoroughly dried and visualized. Here it looks as a white spot lesion on the maxillary cervical regions of the teeth. So next is the damaged caries or stage 2. Here it occurs in the child with the age group of 16 to 24 months. The dentine is exposed and appears soft and yellow. The maxillary primary molars are present with initial white spot lesions that is found on the cervical, proximal and occlusal regions. At this stage, the child tends to complain of grain sensitivity on taking cold drinks. The parents sometimes notice the change of color in their own, that is brownish yellow stains on the maxillary incisor teeth, and tend to visit the dentist for the treatment concerned. Next is the deep lesion, that is stage 3. Here the lesions in the maxillary anterior teeth are found to be very large. Depending on the time of eruption, the karyogenicity and frequency, this stage can be reached in even 10 to 14 months of age. The first primary molars are also affected. The upper first primary molars are in the second stage and the lower primary molars are almost in the initial stage of lesion. Here the patient complains of pain while brushing and biting foods. Incidentally, pulpal problems of the maxillary incisors occur, spontaneous pain at night and pain after taking hot or cold drinks lasting for several minutes. This is the traumatic stage 4, where the neglecting all the previous symptoms lead to the traumatic stage. The teeth starting with the maxillary incisors can become so weakened by caries that even a small force on the maxillary incisors might cause trauma to the anterior teeth, leading to only the grossly destructed root stems on the maxillary incisors. The maxillary first molars are in the third stage and pulpal problems are often seen. Here the patient complains of pain often in spite of having no stimulus like eating. The maxillary incisors have already become non-vital in most of the cases. The mandibular molars are in the second stage of process. The upper canines and second primary molars have lesions that is in the second stage. So here we are going to compare the main difference between the nursing caries and rampant caries. Nursing caries is a specific form of rampant caries. It's seen in the age of infants and toddler time period. It mainly affects the primary dentition and the maxillary incisors and molars are the most commonly affected ones. Here the etiology is mainly because of bottle feeding, pacifiers that is dipped in honey and artful breastfeeding process. The treatment mainly involves topical fluoride application on frequent visits and maintenance of teeth with proper oral hygiene practice. Prevention is mainly focused on the education, that is the primary sorts of prevention are mainly followed for nursing caries. When talking about rampant caries, it's acute, widespread and rapid form of caries involving all age groups. This affects both primary and permanent dentition. Here the mandibular incisors are also affected and the cause is multifactorial like diet, improper oral hygiene, improper feeding practices and not following a proper diet chart. The treatment mainly involves pulp therapy and dental health education for prevention. This is about the stages of nursing bottle caries that was given by Vircam and Virijam in the year 1995. The initial stage is seen in average of 10 to 20 months where the maxillary anterior teeth have a opaque white spot initial lesion. In damage stage, it's seen between the age group of 16 to 24 months where the maxillary anterior teeth are yellowish brown in color. In case of deep lesions, it's seen between the age group of 20 to 36 months. Here, the maxillary teeth have marked enamel defects. In traumatic teeth between the age group of 30 to 48 months, the maxillary anterior teeth, there is more loss of enamel and dentine. This is about the epidemiology about the ECC, where India is the most commonly top affected country with the proportion of 65.5%, followed by Indonesia constituting to 48% of the people affected by dental caries, and the least is England, where only 3.1 to 12% of people are affected by caries. So what is the main etiologic factor for this ECC? The main important factor is Streptococcus mutans, where there is a rapid demineralization and cavitation of enamel that leads to rampant caries. The basic karyogenic microorganism on fermentable carbohydrates produce some acids in the oral cavity that is susceptible to the tooth surface. This acid in turn causes demineralization of the tooth surfaces, leading to a huge big cavity process. So, this is the current concept of caries process, where the primary factors include host, flora, substrate and time factor, that's given by Newburn in the year 1969. So, first we will consider talking about the tooth factor. It's mainly seen in newly erupted immature teeth. There is high prevalence of caries affecting the hypoplastic primary teeth, and this is more common in patients with a low salivary flow rate, patients with salivary gland dysfunction, immature specific defense mechanism, patients with some medical conditions like the immunocompromised patients. And talking about the morphology, in case of mandibular teeth, it's seen in first occlusal, buccal, mesial, distal and lingual, whereas for the maxilla it's occlusal, mesial, lingual, buccal and distal. These are the surface that is affected section by section. So, next is about the salivary factor. McDaniel in the year 1977 told that during sleep it is less than 0.01 ml of saliva per minute that is produced. This decreased salivary flow even increases the risk factor for dental caries. During feeding process, whereas the salivary flow is increased, that is greater than 3 ml per minute. Likewise, Schwartz et al. In the year 1989 told the balance between demineralization and remineralization can affect substantially the tooth with the salivary flow also. Dan in the year 1975 quoted that a maximum salivary flow rate which can be tested by collecting all the saliva using the wax is less than 0.7 ml per minute, that is associated with high risk of caries. Then coming back to Streptococcus mutans, Cafield in the year 1992 represented that the transmission of Streptococcus mutans to human infants is usually from the mother to the infants in the process of kissing, affection or sharing the same utensils, same food that is shared by the mother and the kid. Next is about the window of infectivity. In 1993, Cafield and colleagues presented a paper with evidence of support disease talking about the window of infectivity for MS colonization. Oral bacterial levels of 46 mother-child pairs from infant birth to child 5 were studied to determine the age acquisition of Streptococcus mutans. Cass et al. In the year 1967 told 2 to 6 years of age child is less susceptible to acquire mutants Streptococcus. Window appears to be closed for all primary teeth erupt. Once a stable plaque or biofilm covers the tooth surfaces, MS is less likely to get established in the oral cavity. A second window is speculated to occur when the first molars are erupting. So, the transmission of Streptococcus mutans is mainly through saliva, where the strong correlation occurs between the mother and the child. The most common routes of infection are with close contacts every day, nursing items such as pacifiers, bottles or the spoons that is shared by the mother. So, here talking about the Streptococcus mutans, the mother is found to be the main culprit to transmit mutants from her to the child. Most contact are by utensils, kissing, etc. Here the bacteria is carried even in utero and through breastfeeding. Here the mother spends most of the time with the child, so mother is considered to be the main culprit. So, the transmission is mainly through saliva, where it harbors Streptococcus mutans. Quantitative amounts are positively correlated between the mother and the child during this process. Other factors affecting the acquisition of Streptococcus mutans: the number of erupted teeth, presence of enamel hypoplasia, the amount of fermentable carbohydrates that we consume, the content, consistency, frequency and the time period of carbohydrate that is present in the oral cavity, and antibiotic intake. That's because frequent intake of antibiotic usually has some of the sugar additives added to it. the sugar additives added to this antibiotics and routine intake of antibiotics can lead to caries process. Next is about the pH buffering system. Continuous feeding of sugars at night time decreases the salivary flow rate and increases the risk for caries significantly. The other bacteria apart from Streptococcus mutans that causes dental caries is lactobacilli, where Bo in the year 1987 shown that lactobacillus is present in high numbers in pigmented lesion on patients affected with ECC. The other strains of ECC include Streptococcus sangius, Mitter, Streptococcus salivarius and Streptococcus milleriae. Next is about the substrate. It includes the karyogenicity of sugars, the adhesiveness of foods in oral cavity. If we take sticky foods, it tends to retain in the oral cavity for a very long time period, thereby increasing the risk of caries for that kid. Oral clearance of carbohydrates and frequency of sugar consumption. This is about the karyogenicity of sugars. Whipholm study. In this study, Gustav Sun et al. In the year 1954 firmly established the increased frequency of fermentable carbohydrates consumption and reduced oral clearance as being related to high incidence of caries. Oral clearance of carbohydrate, again Abe in the year 1979 quoted that oral clearance of carbohydrates mainly depends on the salivary flow rate and the thickness of the food material to the tooth surface, and also the frequency of sugar consumption is found to play a very important role when you talk about caries. Next is the main culprit, that is milk of normal consumption has a specific gravity varying from 1.023 to 1.040 at a temperature of 20 degrees Celsius. So this is about the karyogenicity of milk, where Weiss BB in the year 1966, Reynolds et al. In the year 1982 told that milk has a combination of anti-karyogenic components in readily form. It contains casein, IgA, calcium and phosphate. So these all enhances the remineralization rather than producing demineralization of the tooth surface. So in human milk, these concentrations are relatively low when compared to the bovine milk. So the bovine milk is even more karyostatic when compared to the human milk. Human milk contains 7 grams per 100 ml of lactose, whereas bovine milk contains 4 grams per 100 ml of lactose. This is about milk formulas. This includes dicalcium phosphate, which has got high significance for the karyogenicity, and also the sucrose that is added to it even more worsens the karyogenic process. This is given by Bowen in the year 1980. Next is acidic fruit juices and carbonated beverages. Usually the acidic fruit juices decreases the salivary pH, making the salivary pH even more below the critical pH. That is, the salivary pH goes below 5.5, which increases the acidic content, leading to caries process to occur in the oral cavity with the demineralization process. This is about the bovine milk. Actually, to speak, milk is not karyogenic. Milk may exhibit some karyostatic effect. It decreases the solubility of enamel. The mechanism of action is that it decreases the demineralization and increases remineralization. This is because of increase in calcium and phosphorus concentration in the dental plaque that is coated with the milk into the oral cavity. Increased acid buffering capacity of plaque, and moreover milk contains casein and sodium caseinate. It inhibits mutants Streptococcus to saliva coated with hydroxyapatite. So this is a small comparison of human milk with the bovine milk. Human milk is more karyogenic than bovine milk because of the high lactose content of 7%, which is twice as that of bovine milk. Bovine milk has higher concentration of calcium and phosphorus, so the remineralization is relatively very less when you compare it with the human milk. This is also bound in organic molecules and free in ionic form, that again enhances the remineralization process. These bioavailable ions usually favor remineralization process. Next is about the infant formula. Most of them have shown to be acidogenic, and the soya infant formula has got a lot of sugar additives added to it, which again increases the risk for caries process. And the medicinal syrups that the infants daily consume on a routine basis contains a lot of sugar additives added to it, which again increases the risk for dental caries. The acidic fruit juices usually contain low pH The acidic content even more worsens the pH content of the saliva in the oral cavity, leading to more demineralization, worsens the condition. It can even lead to a condition called erosion in the oral cavity. Next is about tooth brushing, where Freeman et al. In the year 1989, Stewart in 1991, Erickson in 1991 and Beck et al. In 1992 and other authors found a strong correlation of oral hygiene habits and prevalence of dental caries associated with it. Next is about the temperament of child. This was given by Thomas and Chess in the year 1977, where children who exhibit greater sleeping difficulties have higher risk for developing early childhood caries. The other secondary factors which are associated with ECC are neglect, siblings and family, pacifiers and medicines. The risk of dental caries is mainly quoted by the formula. It can be calculated where the number of microorganisms into virulence into time into diet by the preventive mechanism. So talking about the socio-economic status, ECC is very much prevalent to 1 to 12% in case of developed countries, whereas in developing countries 50 to 70%. So what are the complications that we can encounter when we have ECC? The first thing is pain, where the patient comes with the chief complaint of pain when he or she is affected by dental caries. The loss of appetite, where the patient is not able to consume food on a regular basis because of pain in mastication. Emotional irritation can affect the permanent teeth also, wherein the primary teeth can spread the infection to the succedinous permanent teeth. Patient will have a swollen cheeks due to dentoalveolar abscess that it might develop in the future. The patient might not be able to freely speak to the society of the people that they come across. So the speaking problems come. The patient will tend to develop a low self-esteem, socio-economic problems, low weight because of improper feeding practices and slow growth because of improper nutrition that he is unable to follow. So there are certain predictors of ECC and risk assessment. The first thing is take a proper case history of what kind of diet or food the patient is following. On clinical examination, it's mandatory to note whether it is the first dental visit, so that it gives a hint of what kind of importance the patient is giving for the dentist. Next is microbial sampling, wherein you collect the saliva and go for the microbial colony counts. Thereby you can enhance the risk factor that the patient might develop for caries in the future. This is about the clinical features. Nursing caries has a characteristic and pathognomonic. It follows a sequence of maxillary central incisors affected first, followed by the maxillary lateral incisors, then the maxillary molars, maxillary canine and second molars, then comes the mandibular molars and incisors. And that's how the progression of lesion begins from one to the other. So these are the consequences that you are going to face when ECC develops. Next, we are going to talk about how we can prevent such kind of early childhood caries. The first thing is the white spot lesion can be remineralized in a minimally invasive procedure. How could we remineralize? The main thing is fluoride that is applied 3 times in a 10-day time period sequence. Fluoride is applied at home. A fluoridated dentifrice is advised to the patient to be used twice daily. Application of 1.1% of sodium fluoride gel by toothbrush is recommended for very risk children with dentine affected by caries. Xylitol chewing gums can be recommended for patients who consume chocolates regularly. So for the alternative of chocolates, this xylitol chewing gums can be recommended as a source of calcium. Cheese can be recommended for remineralization process. So once the caries has developed involving the enamel and dentine, we can't do anything as minimally invasive dentistry process. We have to make the cavity and then restore the teeth in an aesthetic sense. That is what we are going to see now. That is the restorative treatment plan. For anterior teeth, usually it is acid etched and composite resin restoration is used. Pedo strip crowns can be used to retain the morphology of the original tooth structure. Glass ionomer cement restoration can be used because it's very biocompatible and it adheres to the tooth as much as possible. For the posterior teeth, it's posterior composite resin restoration glass ionomer cement restoration and stainless steel crowns to maintain the retention and morphology of the tooth structure, because it aids in the masticatory force and withstand all the masticatory force when you go for crowns in the posterior teeth. So, extensive cavity with pulpal involvement, either pulpectomy or pulpotomy can be done, followed by stainless steel crowns. If it is a very grossly destructed tooth where you cannot replace the morphology of the tooth structure, then extraction is the only way possible, and then you can go for a space maintainers until eruption of the succedinous permanent tooth in the oral cavity. The kind of space maintainers can be either removable or fixed. So, partial or complete dentures can also be used when you think about the removable space maintainers. On a long term follow-up, every 3 months the patient has to be recalled and reviewed whether he is maintaining a proper oral hygiene with a proper dietary pattern and diet practices. So, prevention of ECC. What is the main thing that we have to think about? It's mainly focused on to restore a healthy smile and a happy smile for the patient in the future. This is about the preventive aspects that we have to focus on. First is dental public health education, prevention of transmission, that is Streptococcus mutans. You have to prevent its transmission from the mother to the child. Prenatal visits. So, once the mother is expectant, like during the time of pregnancy, you give a prenatal education for the mother so that he follows all the dietary practices for the proper mineralization of the teeth and bones that is found to develop for the fetus in the oral cavity, thereby preventing any hypoplastic defects that is found to occur for the child in the future. Once this is prevented, the teeth becomes very strong with high content of calcium and phosphorus, thereby preventing cavitation for the child in the future. For the oral hygiene practices, we divide it into two types. One is for the infants with the age group of 0 to 1 years, and for the toddlers it's 1 to 3 years. Here the nursing advice has to be even more enhanced. This is the guidelines for promoting good nutrition and decreasing the risk for dental caries for the child in the future, where you discourage the behavior of placing the child with a bottle to the bed. Prohibit dipping the pacifiers in sugar, honey or any medicated syrup. Discourage a child from carrying and continuously drinking from a bottle or a sippy cup. Fruit juices can be offered only in a cup rather than giving them in bottles. Introduce the cup to begin weaning from the bottle before the first birthday. Reduce the use of beverages other than breast milk, infant formulas or water. Infants should be started with non-liquid diet from 4 to 6 months of age. So, talking about the dietary advice and protective food, there is something called as Indian food pyramid, which is commonly used and advised for all the kids that come to the routine dental visit, wherein the first base is advised to go for cereals, sprouts and healthy food, wherein 3 to 4 servings of fruits and vegetables or 2 to 3 servings of fruits and vegetables, then the milk meat group, followed by oil, which has to be used as sparingly on the possible on the top of the pyramid, that is coated. So, guidelines for the children we categorize into 3 types. First is from the birth to 3 months of age for children with the age group of 3 to 6 months and for the age group of 6 to 12 months. First we are going to talk about for the child with the age group of 1 to 2 years of age, where you discourage the child going to bed with bottle. Complete the weaning of infants from the bottle. Discourage the child from carrying and continuously drinking from bottle or sippy cups. Lime juice or sugar containing intake should be avoided as much as possible. Restrict all kind of cariogenic foods. Establish routine healthy meals following the food pyramid and dietary pattern. Stimulate the child's appetite at meal times by reducing in between meal snacking, which mostly reduces the frequency of intake of junk foods. For the age group of 2 to 4 years of age, promote nutritious non-cariogenic diet for meals as well as for the snacks. Strongly discourage the consumption of slow eating, especially sugar or the sweetened carbohydrate food. Encourage the majority of food consumption at regular meal times and cut in between meal snacks. So, next is about weaning. It is essentially the expansion of diet, wherein the child between the age of 3 to 6 months, when the child is between 3 to 6 months, you expand the diet from a liquid to a semi-solid food then you gradually shift the child to a solid food. It is defined the process of expanding the diet to include food and drinks other than the breast milk or infant formula. Informs a part of social development, bringing the young child towards eating practices and meal patterns within the family. That's given by Hall in the year 1966. So, the timing for weaning is not earlier than 4 months and not later than 6 months of age. The eruption of primary dentition, the weaning can be started even between 3 to 6 months of age. The eruption of primary dentition usually starts during or after the establishment of weaning. The weaning may directly or indirectly affect the onset of dental caries process. So, there are certain stages in the weaning process where the initial stage is from 4 to 6 months we usually follow. Some dentists even advise to go for weaning by the age of 3rd month so that it doesn't increase the onset of dental caries for the patient who are at will breastfeeding or bottle feeding. So, solid or semi-solid food preparations are prepared at home free from added sugars, should be given in a spoon that is not mixed with milk or any other artificial sweeteners. Drinks in a bottle should be avoided. So, the second stage of weaning is between 6 to 9 or 9 to 12 months of age. During the second stage, solid food become important source of energy and nutrient. So, most of the mashed fruits and vegetables are cooked, mashed, then fed in a spoon for the kid. The third stage then marks the progression to a more matured form of diet within the addition of snacks and drinks. So, this is given by Johnson in the year 1997, where at full bottle feeding can be omitted if you follow this process. During the first week, 1/3 of the bottle is filled containing with water. During the second week, 2/3 of the bottle containing water with the rest of it added is milk. And the third week, only water is used rather than milk, that is completely avoided for the child. So, on prevention, there is parent education and identifying the high risk patients. For parent education, you have to first check about an alternative for this nocturnal feeding habit practice. And for the weaning methods, diluting the liquid as given by Johnson can be used, and the patient should be encouraged to use a cup rather than using a bottle by the age of 12 months at least. Avoid sweetened pacifiers, sharing the utensils to avoid transmission of Streptococcus mutans. Clean the gum pads using a sterile gauze piece. The sterile gauze piece is rolled in an index finger, and then clean the gum pads with a saline, that is into the oral cavity, to clean the oral cavity of the patient. So, this is about the AAPD policy statement for the prevention of early childhood caries, where the infants should not be, again this is again insisted as by the other authors, the infant should not be put in bottle to bed. Nocturnal breastfeeding or at-will bottle feeding should be mostly avoided as much as possible. This has to be even more enhanced when the first primary tooth tends to erupt in the oral cavity. Patients should be encouraged to have infants drink in a cup rather than giving it in a bottle. During at least by his first birthday, infant should be weaned between the age group of 12 to 14 months of age. At least by 12 to 14 months of age. If it persists beyond this, it might lead to caries risk. Repetitive consumption of any liquid containing fermentable carbohydrates in a bottle or no spill cup should be avoided. Oral hygiene measures should be implemented by the time of eruption of first primary teeth, which reduces the risk factor for dental caries. A oral health consultation visits should be done when the first primary teeth erupts in the oral cavity, that is by the 6th month of age, and not later than 12 months. At least when the child is by the age of 1, he has to visit the dentist, and not less than 12 months of age, the dentist should be visited. Recommended to educate the parents to provide anticipatory guidance for prevention of all kinds of dental diseases. An attempt should be made to assess and decrease the mother's or primary caregivers' mutant streptococcus levels to decrease the transmission of cariogenic bacteria through saliva, and this mainly reduces the risk of transmission of early childhood caries. So, these are all about the preventive aspects. Talking about the definitive treatment, once the teeth is affected and damaged. What kind of treatment can we do for such kind of patients? The first thing, once the pulp is completely affected on the coronal aspect, is pulpotomy, wherein you completely remove the coronal portions of the dental pulp and restore it with a biocompatible material, and pulpectomy, wherein complete extirpation of coronal and radicular portions of the dental pulp and then fill it with a biocompatible resorbable material until the permanent teeth erupts in the oral cavity. All these pulpotomy and pulpectomy treated teeth should be restored with stainless steel crowns so that the teeth will have sufficient strength to withstand the masticatory forces. If at all the teeth is completely damaged with a continuous sinus opening and pus discharge, where you can't restore the tooth, the only option left is extraction. So for what are the kind of full restorations that we can go ahead in a pulpectomy or pulpotomy treated teeth? The full coverage restoration mainly enhances on stainless steel crowns or aesthetic concern of zirconia crowns, or indirect composite resin restorations can also be done in case of wide cavity that is present. So this is a pre-operative picture of a teeth that is mostly affected with caries. This is the maxillary incisors, wherein the crown structure is completely destroyed. The pulpectomy is done to get a better retention with the placement of composites. The fiber posts are placed. Strip crowns are then used in the third picture to retain the morphology of the tooth, and then the post-operative picture with the placement of composites with the help of strip crowns. So what is the main thing that you can enhance to prevent dental caries or the early childhood caries? The right counseling is mainly enhanced by the pediatric dentist in dental practice. So before counseling, explain the reason and importance of dental counseling so that the patient will be able to appreciate the value of it. Dental health diet score is taking the diet chart, food intake and diet diary are preferred. Combining the sequence of foods. If the patient can't avoid sugary foods, you can add sugary foods to proteins and limit the amount of fat that the patient is taking. Fermentable carbohydrates with a non-sugary item, inclusion of milk with a non-fat yogurt, cheese, peanuts, then peanuts with apple juice, drinking water. So healthy smile and a happy child are the main motto of a pediatric dentist. To enhance this, we have to follow these protocols to give a non-preventive form of healthy smiles. To conclude with, the magnitude of effect of early childhood caries is overwhelming. Its effect extends beyond the reams of the oral cavity. It adversely affects the orthodontic and aesthetic development of the child, thereby stunting his psychological needs. It might even impair the social self-esteem of the child. So physically, the child's growth is equally curtailed, where an ECC affected child is shorter and even malnutrition. Because of this, he went in underweight, his IQ gets underdeveloped, and it might lead to future more complications. But the good news is that you, that is the dentist, can have a better chance to deal with this situation more effectively. So let's make use of it. So to conclude with, it's again a combination of all these three people who have to work hands in hand. One is pediatrician, child specialist who has completed pediatrics, then the periodontist and the parent who has to work hands in hands with the child to give a good, happy, healthy smile for the kid. For the reference, you can just refer these books. So thank you all for watching this lecture. Thank you all for the wonderful opportunity given.